for, that's even better. I'll explain that as we go along. And we're just talking about that in relation to orthopaedics and orthopaedic patients, and then what the risk is for our orthopaedic patients. So even if you're working in different areas, there's still quite a high risk of VTE in orthopaedic patients as well. So what I'll go through tonight is some of the basics around VTE, some of the research that's been published around VTE in orthopaedics, some of the prophylactic options in terms of trying to prevent VTE, some of the prophylaxis I used in my workplace when I was in the Royal Adelaide Hospital. So I don't work there anymore, but I'll describe that. And each area and each hospital have quite a different practice in terms of preventing VTE from occurring. We had a local orthopaedic nurses group in South Australia a few years ago. We did some review of patients and incidents of VTE, so I'll talk a little bit about that. And if there's any answers that are possible for VTE in orthopaedic patients, I'll talk about them, so we'll see how we go. Alright, so to start off with, VTE stands for venous thromboembolism. So obviously that's a sort of relatively new term, probably over in the last maybe 5 or 8 years or so. Before that, you know, there was separated between DVT and PE. So a VTE is either a DVT and or a PE in itself, but really any sort of thrombus or clot that occurs. We'll talk about chemoprophylaxis throughout the presentation, as well as mechanical compression as being the two main ways of preventing VTE occurring. VTE is one of the leading causes of preventable death in patients, and not just in orthopaedic patients. So it can be quite a significant issue. So it's something that we need to be aware of and in practice as well. I guess just going into a little bit more detail, DVT is a clot or a thrombus, so deep vein thrombosis, so it's a thrombosis that ends up in one of the veins, usually in the lower limb, but not always, and it may occlude the limb, so impact on the blood supply distal to that clot. A pulmonary embolus is when possibly a part of that thrombus dislodges and it travels around the circulatory system and ends up in the lungs, and then can also occlude that vessel, which means that there's no blood flowing or limited blood flowing to the area distal or past that clot, which means that the gases exchange in that vessel that runs through the heart, through the lungs, sorry, is not occurring. So you're not getting new oxygen into the blood, and you're not removing the carbon dioxide. So that's obviously a potentially life-threatening disease or occurrence. Now, traditionally, pulmonary embolus was thought of as always coming from a DVT. There's a bit of talk in the literature now that that's not always the case. So if you have a patient that has a pulmonary embolus, it's not necessarily so that they also have a DVT. So that's sort of starting to change a little bit the way of thinking, but it still obviously occurs in some cases. So why do patients or people get clots? Well, there's a number of reasons. There's someone, a man called Rudolf Virchow in the 1800s. He was a German pathologist, and he identified sort of 3 different areas, or he's attributed with identifying. There's maybe a little bit of controversy about that, but anyway, this has come to known as Virchow's triad. So there's 3 different areas of that: circulatory stasis, endothelial injury, and hypercoagulable state. So each of those may be occurring at some level, and that will then lead to a thrombus in the end. So stasis, probably one of the primary causes of thrombus. So that means that there's a decrease in the circulation or the flow of blood due to immobility or inactivity, and that's often the case with orthopaedic patients. They're not as mobile, so that circulation or blood flow is reduced as well. There might be some coagulation changes, So the blood doesn't clot normally. That can be related to elevated thromboplastin or fibrinogen. There might be prolonged stasis that can also increase that state. And then some medications and disorders and illnesses can create that as well. There also might be vessel wall damage, so endothelial wall damage, which may be as a result of direct trauma. So is often the case for our orthopaedic patients. There's direct trauma to their limb, and that ends up damaging the walls of the blood vessels, and that can increase the risk of thrombus forming as well. That can also occur during surgery as well, so that there's a risk in having surgery for VTE as well. So all those three can work together, and they can create thrombus to occurring. So it's also important, though, when we're talking about VTE, is to also consider bleeding. Now, everyone sort of focuses on preventing VTE or treating it once it occurs, but it's really important that once when we're looking at our patients, that we're considering what their risk of bleeding is as well, because if we're treating them with chemoprophylaxis, so chemicals and things like warfarin, to stop them getting a VTE, but we treat them, over-treat them, then their risk of bleeding increases, and that can be potentially life-threatening as well. So that's important that we consider that when we plan how we're going to treat our patients. So there's a number of bodies and guidelines are in existence. This is from the NICE guidelines, the National Institute for Health and Clinical Excellence, from 2010. It's a group in the UK. They did release some guidelines in 2007, and that needed refining, and they did that in 2010. And have released these, and these have been pretty well adopted by a lot of different areas as well. So what they do is they split the risk factors into a number of different areas. So for medical patients, there's some risk factors, so you can see that over, and I'll just circle that there. And then there's risk factors for surgical patients with trauma. And if you notice, that involves the total anaesthetic time and surgical time, so that's a big risk factor. The longer the surgery, then the higher the risk of VTE as well. If there's a lower limb or pelvis or a combination of those things, then the risk is high again. If there's abdominal surgery, that's a risk factor. A significant reduction in mobility, and if any other VTE risk factors are present as well. So what they've done is they've separated the risks into the types of patients in terms of what their injury is or what their illness is, but also risk factors for the actual individual patient as well. So for example, if someone's got active cancer or cancer treatment, that is an extremely high risk factor for VTE, and need to be treated as such, because they're probably going to end up with VTE unless you try and prevent that. If someone's over 60, if they're critical care admission, if they're a bit dehydrated, if they're obese, if they have one or more significant medical comorbidities, if they've had a VTE in the past, obviously that's a really high risk of getting it again. The use of, that's not Hamilton-Russell traction, that's hormone replacement therapy. If someone's on the pill, so if they're on the contraceptive pill, then they're also at risk of getting VTE. And someone who's has got varicose veins as well. So we've got to consider all those things together in terms of how likely it is that they are going to end up with a VTE, and that will influence how we treat them and try and prevent that occurring. So, like I said before, we've got to consider the bleeding risk as well. So, so we should do an assessment, and this is again from NICE in 2010. So if someone's got active bleeding or some sort of bleeding disorder, or even something like acute liver failure, if they've got, if they're using anticoagulants for something else, if they've had a lumbar puncture or epidural or spinal anaesthetic, that's a risk as well. If they've had a stroke, they've got thrombocytopenia, uncontrolled hypertension, and other inherited bleeding disorders, and that's obviously a really high risk for bleeding as well. So when we're deciding how to treat those patients, we need to take that into consideration as well. So VTE, I said before, it's a leading cause of death. It's actually the fifth leading, well, in this report in 2003 by Access Economics, it was the fifth leading cause of death. It's one of the highest leading cause of preventable deaths in Australia, but here you can see it's around, I can't remember the exact figures, 5,000 wasn't it? Yes, 5,000 deaths, sorry. I'm looking at the top, not the bottom. Obviously, there's other disease processes that outstrip that, so coronary heart disease is much higher. But this is also, it's a significant problem. So for a population of 20 million, we've got 5,000 deaths a year occurring. So that's something that we need to do something about. One of the examples that I use in my practice was we had a 45-year-old man who sustained a relatively nasty ankle fracture. He was admitted to the hospital. He was quite fit and well. He was resting in bed because his ankle was too swollen. It was too swollen, and he had some fracture blisters, so he couldn't go to theatre to have it reduced. But he was waiting, and they were hoping to do that in the sort of next day or two. And then one night, he'd only been in for a couple of days. One night he started complaining of chest pain, and then suddenly within a matter of minutes he was dead, and he was not able to be revived. And that was a PE that had killed him, and he came in as a 45-year-old with a relatively minor trauma. So, and the problem was because his ankle was swollen and he had fracture blisters, the orthopods weren't giving him any chemoprophylaxis because that would make the swelling worse and the bleeding into that area higher. So it's sometimes quite a difficult tightrope to walk as well. There's an increase in cost associated obviously with this, so if we can try and prevent that, then we can save the system money. But also make it better for the patients, obviously, that you don't want people dying if they don't have to. So if we can have an impact on that, that's a couple of good reasons to do that. Now, obviously, with some of the research, you would normally try and compare how you use prophylaxis against a control group. Now, we can't do that in today's setting because it's not ethical to not give someone prophylaxis when you know that there's a very high chance they're going to end up with a DVT or a PE. So all we can do is rely on some of the figures back from the early 1990s and even earlier of different surgeries and different sorts of injuries and how much VTE occurred. So O'Meara in 1990 identified that in general surgery there was a 25% prevalence of DVT, and this is only DVT, this is not PE. Went up to 84% in knee surgery, up to 60% in hip arthroplasty, and even up to 100% in spinal cord injury, which is just huge. So again, spinal cord injuries are a very big risk factor for ending up with a DVT or a PE. So we can compare that with practice now. So with prophylaxis, some of those incidents have come down to sort of around 1% to in the low single figures. It's a little bit difficult to compare because there's so many different variables. So there's the patient risk factors against the variables of that against the way someone's been treated with the prophylaxis, so the type of prophylaxis, the dose, the frequency, the length of treatment, they all vary a lot. The surgery type varies, also the length of time in surgery and the length of time in hospital varies, and then also compliance with any sort of regime as well. So it's a bit hard to work out what the actual incidence of VTEs and orthopaedics now, but we can have a sort of rough idea. It's in the low single figures, so it's not too bad, but there's still room for improvement. So what do we want to prevent VTE? Obviously people are dying from it, so we want to prevent that. But associated with that is long-term complications as well. So some studies have said up to 70% of patients that have a DVT will end up with post-thrombotic embolic venous syndrome afterwards, and that can be quite a debilitating lifelong disease as well. I don't know if those figures are, that seems quite high, but it is a problem, and it's something that even if you treat a DVT as soon as you notice it and you provide the correct treatment, patients can still go on to develop this syndrome as well. So the syndrome comprises a number of different things. It's chronic venous insufficiency, chronic edema, chronic pain, and maybe recurrent venous ulcerations as well. So it's something that, if we can prevent it happening in the first place, even if we're treating it effectively once it occurs, it's better to prevent it rather than try and treat it afterwards. So some of the research looks at VTE, specifically DVTs, and what they'll do is they'll scan everyone in the sample group, and that occurs in some workplaces as well. So in some places, every patient who has a total joint replacement will have a scan before they're discharged home from hospital. Now the problem with that is that some patients have got DVTs already, and they're really minor, insignificant DVTs that they may have had anyway despite having the surgery. So what happens if you find that DVT? Do you have to treat it? And then if you don't treat it, what are the risks of not doing that as well? So it's a little bit tricky to work out. What is a DVT? So that might seem like a weird question, but there's all sorts of differences. There's differences where the DVT is located, so if it's in the more superficial veins or in the deeper veins. If it's proximally, so if it's in the proximal lower limb, it's more of a risk supposedly than if it's in the distal lower limb as well. So there's a few variations in terms of what actually is a DVT as well. And then also, when is a DVT or a PE that occurs actually related to the admission? So if someone has a total hip replacement, they're in hospital for say 5 days, they go home and 2 weeks later they end up with a PE, is that related to the hospitalisation and the surgery? Now most places actually, well, the literature is not clear, but a lot of the sort of current opinion is at least 3 months after surgery it's related to that surgery. So if someone goes home and they have a PE 3 weeks later, then you can pretty much safely say that's related to the admission. Alright, so a lot of the research is also focused, well, mainly on cancer, but there's starting to be a lot more in orthopaedics as well, and they're probably the two biggest areas of risk for VTE, cancer and orthopaedics. Some of the other general surgical areas are starting to look at their risk as well, because traditionally they haven't, so that's starting to occur now, but orthopaedics and cancer are probably out ahead of some of those other groups as well. There's lots and lots of research out there which is good in some ways, but then makes it hard to sort of work out what you want to do and what is the best practice, because there's a lot of competing different sorts of studies that may recommend different things, so it's hard for the poor old clinician to work out, what should I really be doing for my patients as well. So that's always a little bit tricky. So sometimes if you're looking at the research yourself, you've got to try and work out if there's any bias in the research. Who's doing the research? Is it some of the drug companies? And a lot of the research that's published is backed and paid for by some of the companies that make the medications that we use. So you've got to be aware of that, because they have a vested interest in the outcome. So you would hope that they don't do anything to influence that, but with some of the papers I've read, there is some sort of novel ways of how they've presented the data to try and make it look a little bit more positive, I guess. So that's worth having a look at. Comparing apples and oranges, so if you're looking at some sort of research that looks at total hip replacements, you're not comparing that with someone who's looking at patients who have ACL done or something of that nature. So you've got to try and keep that in mind as well. We talked about when VTE is related to an ortho mission, there might be too narrow a focus on the research. There's some of the guidelines, and we'll talk about that in a sec, that are available, and we talked about the NICE guidelines already, but there's some Australian ones, and so sometimes that's helpful for the clinician just to sort of accept that they've done the hard work and they've looked at what's the best treatment for different patient groups and rely on using those guidelines as well. And then sometimes the problem is in your practice, you think you're able to see what you think's the best practice or what the literature says, but then the orthopaedic surgeons come along and they've got a different idea and they want to do their own thing, and that always makes life a bit difficult as well. So some of the guidelines that are available for use, so the NICE guidelines, I talked about them. There's also the National Health and Medical Research Council guidelines that were released in 2009. The NHMRC is a body that's responsible for distribution of funds to significant research projects in Australia. So they're really the preeminent body of research funding in Australia. So they've put a lot of time and effort into these guidelines. Now, neither of these guidelines are specific for orthopaedics, but they do have sections in there that are related specifically for orthopaedics. So you can download those and then have a look at what they say. And they're freely available on the internet. So the NICE guidelines, they do recommend an individual risk assessment for every patient that gets admitted. You consider, have they got cancer, are they over 60, are they dehydrated, all those risk factors. It doesn't have a scoring system or anything like that, but I guess the idea is once you've identified one risk factor in there, so if you've ticked any of those boxes, so any of these boxes there or here, then you need to follow that up with a bigger risk assessment, and then have a consideration of designing individual prophylaxis for that patient because they've got some risk factors as well. If they've got bleeding risk, so again they've got the bleeding risk down the bottom here. If they do have some bleeding risk, then you'd need to refer the patient to the haematologist, and then they will again work out what the best treatment plan is for that patient before they head off to surgery, hopefully. And then the other thing to remember is that the risk isn't always the same throughout the admission or the surgery. So when someone comes in initially, they might be at a certain level of risk. Once they go to theatre, they might be at a higher risk for a period afterwards. And then once they start walking, then that risk may decrease. So it's worthy of considering that the risk isn't the same throughout the admission, and so that may influence how you treat that person as well. The NHMRC, this is not the actual guidelines, this is just an overall table of basic recommendations, and it just shows you what they recommend for each sort of surgery. There is much more detail there if you go and look at that as well, but you also need to obviously consider the bleeding risk at the same time. So how can we stop VTE? Well, it's relatively easy. We could almost stop all of it if everyone didn't injure themselves and no one had surgery and everyone walked and exercised. But obviously we're not able to do that, so it's still going to be a problem. So the best things we can do are trying to encourage fluids, early aggressive mobility, so replicate the walking movement. That's the best thing for people. That gets the blood circulating around and hopefully prevents DVTs and PEs occurring. But obviously with our orthopaedic patients, that's very difficult because they've got fractures, they're non-weight bearing, they're resting in bed, they're in traction, those sort of things. So we need to come up with other ways of replicating that walking action. So we'll talk about those in a little while. But also using other types of prophylaxis at the same time to prevent them getting a VTE. So like I said at the start, we sort of split prophylaxis up into two things. So there's chemical and mechanical. There's risks and benefits to both of those. But what we're wanting to try and do is match the treatment to the risk of the patient as well. So we want to consider what the risk is of the patient and then match that risk with the way we're treating them and trying to prevent VTE occurring. So the chemical options, and these aren't exhaustive list, there's much more options than this, but these are sort of some of the more general ones and the ones that are a bit more used in a lot of different places. So heparin, you can give that obviously subcut or IV. It's a short-acting anticoagulant, slows the conversion of prothrombin to thrombin. Low molecular weight heparins, so like your clexanes, they mainly subcutaneous. They're an antithrombotic agent. They have a little bit of a longer half-life. Warfarin is oral. Suppresses vitamin D dependent synthesis factors. It's got a long half-life and a prolonged effect after ceasing administration as well. Aspirin, an example of an antiplatelet agent. Rivaroxaban, that's an example of some of the direct factor XA inhibitors, so the Zabans group. So that's an example of those, Xarelto and Apixaban. There are a lot of the newer generation medications that are coming out as well. They seem to be mainly used for elective surgery at the moment, so they're sort of relatively new, and people, the jury's out a little bit, I think, on their treatment. There is other medications you can use. For mechanical, there's a few different types of mechanical devices you can use. It's important that we'll try not to use the brand name, so we want to describe some of these different things. So for example, instead of saying TED stockings, which is actually a brand name, we should be referring to them as graduated compression stockings. Same thing for foot compression devices. There's a number of those available, and sequential compression devices as well. So the SCDs, or sequential compression devices, they're a leg length stocking that inflates intermittently, so it can be just the lower leg, or it can be the lower leg and the upper leg as well, and that's used to reduce venostasis. Foot compression, like the AV impulse systems from Covidien, intermittent pneumatic compression of the venous plantar plexus on the sole of the foot, so that tries to mimic the walking action as well. The graduated compression stockings, they improve venous return, and by applying graduated compression up the leg, and also trying to prevent venous distension as well. There are some stockings that go above the knee and some that go below, and there were some interesting results in the Stop the Clot trial 2 that looked at the use of stockings with patients who'd had a stroke, and actually found that they weren't that effective for that patient group. The other option too is the inferior vena cava filters, which is a filter that's sort of like a little spidery metal device that's put into the inferior vena cava when other methods of prophylaxis are not able to be used, and it's more of a physical barrier to the clot travelling to the respiratory circulation. So once the clot hits that, it sort of stays there and doesn't travel further on. And obviously there's risks associated with that as well. So the chemical prophylaxis, so there's benefits and risks to that. Obviously bleeding is the main and obvious risk when considering chemoprophylaxis. It can be a serious complication leading to death in the worst case scenario. Hematoma formation, so that can increase the risk of infection, especially around, there's a lot of the surgeons are worried about their total knee replacements ending up with hematoma formation around the knee, and then increasing the risk of infection as well, which may possibly lead to osteomyelitis or something like that as well. Some of the chemical prophylaxis agents are able to be reversed, which is handy sometimes, and that gives us some flexibility in terms of titrating prophylaxis and the dose as well. But medications like warfarin, there's a delay to the effect. So, once you give warfarin, that doesn't come into effect until the INR is therapeutic. And then there's also a delayed effect after you cease the medication, that there's still a anti-clotting effect after you've stopped giving the medication. So that does make it a little bit tricky as well. Depending on the types of medications as to how cost effective they are, it means things like clexane. If you want to give clexane at home once someone's discharged, then there's costs associated with that in terms of having to get nurses to visit the patient's home and give it if the patient's unable to give it themselves. Whereas some of the tablet formations, that means the patient can just take that themselves and it's much easier. Things like warfarin, so patients need to be monitored regularly to check the INR levels, so there's costs associated with that as well, and it means that the patient has to then somehow get to the clinic to have the blood taken on a regular basis. So there's a whole heap of different sort of benefits and risks associated with some of those things as well. Mechanical, again, there's benefit and risk as well. So probably one of the risks, well not risks I guess, but the considerations is the cost. Some of the devices are relatively costly to use, so some of the pads can cost quite a lot. But I guess if you can demonstrate that over time that that's saving a number of VTE occurring and therefore decreasing cost, then that may be of a benefit, but that's hard to argue that sometimes. I know when we started using the foot compression devices in the Royal Adelaide Hospital, the cost was significant at the start, and there was a lot of pushback from some people in terms of the budget, so that was hard to sort of to argue against that, I guess. They can reduce the mobility of patients, so if they've got things attached to their legs, it's harder to walk around. They can be removed for short periods, I guess, but there's some debate about how long they should be off as well. There is problems like it does take time for nurses to fit them, make sure they're fitting them correctly, monitoring their use. There is some discomfort experienced by patients, so patients might complain that it hurts or it's uncomfortable or they can't sleep with it going because it's going 24 hours a day. So that may be a problem, although some of that stuff seems to settle down. People get used to that relatively quickly as well. Some of the benefits are you can actually use them with certain injuries. So for example, the foot compression devices you can use under traction. So skin traction, you can actually put it under that, as opposed to the SCDs where if someone's got a femoral fracture or a tibial fracture, you can't use those. So there is some benefits to some of those as well. There is some contraindications for sequential compression devices and foot pumps, so severe peripheral vascular disease, peripheral neuropathy, skin grafts, infected limb, or a current DVT are contraindications. But I guess the biggest benefit of mechanical prophylaxis is that if the patient is unable to have chemical chemoprophylaxis because they're at risk of bleeding, then you can still use mechanical compression. So that gives you an option for, say, window periods. For example, if a patient comes in with a pelvic injury, for the first 2 days or so after that injury, they're not able to have chemoprophylaxis because they're actively bleeding into their pelvis. So in those periods you can then fit mechanical compression devices, and then same scenario after surgery, maybe for 2 days you can't use the chemoprophylaxis. So for that window period you can then add mechanical compression to try and prevent VTE occurring as well. So that's, I guess, one of the main benefits of mechanical. And the real recommendations are that you use the two together, and that's the best for the patients as well. So some of the go into some bit more detail about some of the chemical examples. So heparin, it's got a shorter half-life, it's quick acting, and it can be monitored. That's the benefit. The limit of it is it's needed more often than daily and needs to be monitored, and can't really be given at home. So the patient needs to be in hospital. Aspirin, the benefits, patients able to self-administer it once a day, it's low risk. The limit, query the level of effectiveness on its own, which has been debated in the literature. The low molecular weight heparins, the benefit is it's once a day for prophylaxis, it's already prepared, it's in a syringe, and you can teach the patient to give it themselves. The limit is it costs a little bit more. You do need to teach the patient, that can be a limit. If they can't do that themselves, then you need someone to visit their home and do that on discharge. You can't really monitor the levels, it's not easily reversible, as is heparin. and there's implications for surgery and emergency admission. Because it's got a longer half-life as well. Warfarin, warfarin's very effective in preventing VTE, but conversely, it can increase the risk of bleeding quite severely. It can be self-administered. You can titrate the dose so you get a proper level, effective level, and it is reversible. That's one good thing. The limit, though, is you do need to monitor the levels, and that can be costly and time-consuming. The INR can go too high quite easily, and that can then have a significant risk of bleeding. And there's the delay after stopping the medication. There's a therapeutic delay. The therapeutic effect continues afterwards. Rivaroxaban, those sort of medications, they're easy to administer for the patient. They're once a day. The limit may be with the cost, but as they get used more and more, that may become a bit cheaper. And they're relatively newer and used in elective cases so far. There is a little bit of discussion that they do increase the risk of bleeding, however, so that can be a bit of a problem. Now, there's meant to be a little picture, a video there, but it doesn't come through on the system, sorry. But we'll talk about the SCD. So the benefit of the sequential compression devices is that they're effective. They're a bit cheaper than the foot pumps. The limit is that they can be restrictive. They can limit mobility for a patient that's mobilising, and you can't place it over some injury. So if they've got a femoral or a tibial fracture, they're hard you can't use them then. The foot pumps, the benefit is that they can be used with a greater range of injuries. They're easier to apply, they're less restrictive. You can apply them under traction. The limit is they cost a bit more. The patient tolerance might be a little bit worse, and you can't use if there's an existing DVT already. The graduated compression stockings, they're obviously a lot cheaper. They can be applied by the patient and can be quite effective. The limit is sometimes they're quite hard to apply. Trying to pull them up on someone's leg who's got quite a large leg can be difficult. They can cause skin problems, and then if they're fitted incorrectly, they can actually cause more harm than benefit as well. The inferior vena cava filter, is the benefit is that once it's in place, there's no more care needed, but the limit is there's a high risk of that sort of surgery, and you're not sure if it'll stop all the clots, and then also there's a need to maybe remove it later on. So the practice at the Royal Adelaide, when I left, they had a flow chart, and that's on the next slide. I'll show you in a sec. That explains. It looks a little bit complicated, but it was actually a little bit simpler to use in practice, and it had included some specifics about patient injury, about the patient themselves, but then also varied depending on the type of injury and the surgery as well, which is important to get that balance, I think. The main part of the flowchart was there's some options when chemo prophylaxis was contraindicated, and that's the example I used with the pelvic injury. All right, thanks, Wendy. So for those window periods when you can't use chemo prophylaxis, so we used the AV impulse foot pumps for those as well. So that's the flowchart there. You won't be able to read that, sorry, because it's very little and not a fabulous picture. And it does look a little bit more complicated than you would think, but over time people seem to get the hang of that, and they felt comfortable using that as well. One thing we do talk about too is how do we actually know what the actual incidence of VTE is? Because we think we know, but I suspect we probably don't know as much as we do. So while patients are in hospital, and if they end up with a VTE, then we know that, and that's quite good. But once they're discharged home, we're probably not finding that out as well as we may expect. There has been some studies by White et al. In 2003, and it wasn't just ortho patients, and that was quite a big study. It was 1.7 million cases, and they found that up to 50% of VTE occurred after discharge. There's another study by Keelis et al., and they suggest that VTE occurred around 15 days post-procedure. So if you imagine that patients are staying in hospital for less and less time, then a lot of that VTE is occurring after someone's been discharged home. So a good example is if a patient's, say, admitted with an ankle fracture, they have the fracture fixed, they're in hospital for a couple of days, and then they're discharged home. And then about a week later, they end up, with some calf pain, and they go and see their local doctor, who recommends they go to a different hospital because it's closer. It's not where they had their accident. So they get admitted to that hospital with a DVT. Now, the initial hospital, the initial treating doctors, the initial treating unit doesn't know that patient's been readmitted with a DVT. So they're not basing their understanding of the incidence of VTE on anything that's really solid. So there might be a whole bunch of hidden VTE that's occurring that they're not aware of as well. Now, the implications for that are that they think their practice is working really well for their patients because they're not seeing all these DVTs, but in actual fact there's a whole bunch of DVTs that are occurring that they don't know about. So that's has implications for the way we treat our patients. So there's a group of South Australian Level 3 orthopaedic nurses that met in 2009, and we decided we wanted to have a look at their current practices, what the actual VTE incidence was, what the bleeding incidence was, what readmission rates were, and then we wanted to report those results back to each individual unit as well. So what we did was we did a retrospective case note review of a random sample of patients. I think we ended up doing 120, I think, from memory. And we looked back at any readmissions, any VTE and bleeding incidents for 3 months post-discharge. We looked at the different protocols, and then we reported those results back to each of the hospitals as well. So it took a long time to do. It was quite a big project, but it was quite interesting, and we came up with some very interesting data that showed that some places where the incidence of VTE was much higher, then the risk of bleeding was lower, and then the same was converse in some other hospitals. So some places that had really high bleeding that didn't have hardly any VTE. So it's a good way of identifying what's occurring in your local practice, and it's something that you can consider in your local practice as well. So what are the answers? Are there any answers? No, there's not, unfortunately. So there's no magic answers. There is an emerging database, though, of evidence, and it really looks at knowing the risk factors for your patients, so individual patients, but also as individual groups. So what I mean by that is, is your patient over 60 years old? Do they have active cancer? Are they obese? Those sort of risk factors, but also individual groups. So total joint replacement patients, spinal patients, those different groups are high risk as well. So what we want to do then is match the risk. Once we've assessed each patient, we want to match what their risk is. We want to use a multimodal approach to prophylaxis, so using mechanical and or chemical, where fits in with each individual patient, and then making sure, obviously, that we're doing early and aggressive mobilisation as well. So what other answers are? You can look at what occurs in your practice as well, so be aware of what the protocols are for VTE prophylaxis in your workplace. Try and see if there's any gaps that need to be filled in. Educate your patients, tell them what to look for, tell them how to prevent VTE. Try and identify what the real VTE evidence, the real incidence of VTE is in your workplace. Are there deaths that are occurring from VTE that aren't identified? Are you getting all the data that is needed to be able to make an educated decision as well? And argue for use, even including nurses in VTE assessment, and even having a nurse that's whose primary main role, as it's better to say, is mainly focused around VTE. And obviously there's always costs associated with that, but in the long run, if you can save even a small number of VTE, then you might actually save some costs in the long run as well. And this is what's been demonstrated by NICE in 2010, that there was a cost associated with implementation, but the overall savings was a greater over the longer period. So, and the other true cost saving is the lives of the patients, and obviously minimising the long-term problems as well, and the well-being of the patients, which is really the most important thing. There's some references there. I'd also like to acknowledge the members of the group, the SAVETON, the local South Australian group, and also Jenny Ritzes from Covidian, who supported that group. And that's where we're finished. So thank you to everyone for coming along, and